I think that for the last few minutes, for time issues, about the treatment of diffuse large B-cell lymphomas. Again, diffuse large B-cell lymphoma being the most common subtype of lymphoma that we treat. It makes up maybe about a third of the patients. What I like to say is that over the years, we're still seeing the patients with diffuse large B-cell lymphoma in numbers, but we're getting a better idea of how to prognosticate and how to actually fine-tune our understanding a little bit about the disease and about which patients actually may require more aggressive intervention. And again, prognostications such as with the either FISH or looking for these patients that have, say, very poor prognostic disease. So prognostic factors, you have the International Prognostic Index, but it still holds true today no matter what, even novel therapies. But looking in these patients, looking at FISH for Myc and or BCL2 rearrangement, was so-called if you have both a double hit. Very dismal results. We're not sure what is the optimal therapy. We often have discussions when we just talk about large cell lymphoma, what to do for these patients. I think what the future will hold is that, you have a tumor that's growing fast and it's chemo resistant. So if we can maybe use, I believe the future is ABT-199 even, by making that tumor cell less chemo resistant. We know that even because, for example, Myc, patients that have just Myc rearrangements, c-Myc, they actually do worse than those patients without, but not, the BCL2 adds another degree of resistance. But it is interesting that we can talk about, treatment options. Right now, R-CHOP, there was a long discussion in the past years, R-CHOP 14 versus R-CHOP, given 2 weeks or 3 weeks. I think the general standard is most people feel R-CHOP every 21 days. There's no real true benefit in giving R-CHOP 14 for the majority of patients. The large study from the CLGB, from the Alliance, looking at R-EPOC, which is from the NCI, Wyndham Wilson has championed that, versus R-CHOP, is going to be very interesting. The data, we've accrued the patients, now gene expression profiling is going to be done, and with long-term follow-up, we're going to see if there are subsets of patients which truly may benefit from the infusional R-EPOC type of approach. Right now, I think most clinicians believe that in patients, and truly in our own group, patients that have Myc rearrangement, patients that have primary mediastinal B-cell lymphoma, and in patients that actually have what appears to be, for we're given the best, that R-CHOP is not very effective in, that R-EPOC, we do utilize it, and a lot of physicians are utilizing, although, there is an issue. You just need to realize it's going to be a 4-day continuous infusion of the vincristine and Adria and etoposide, is that the results are actually quite promising, and there's going to be some updates at this meeting also with respect to the R-EPOC. Now, what I would throw out is that the reason also in the Myc-positive or in those patients we used to call Burkitt's-like is that actually R-EPOC actually is a regimen that works in Burkitt's lymphoma. Therefore, I think I would just mention that if you have a patient, you get back and practice that it's Myc-positive, and you have to look for it or request, then R-CHOP, in my opinion, is inadequate for that patient as it's inadequate for patients with Burkitt's lymphoma. So I think that those are